Welcome. In this session, we'll be discussing about Rhegmatogenous retinal detachment. We'll be discussing about traction, combined and exudative retinal detachments in the next session. Retinal detachment is a separation between the neurosensory retina and the retinal pigment epithelium and is an important cause of visual disability because the photoreceptors receive their metabolic support from the retinal pigment epithelium and the choroid. Untreated, persistent symptomatic RD generally results in total blindness, and so RD requires prompt treatment to salvage vision, at least partially. Retinal detachment occurs when the physiological forces maintaining the normal adhesion between the neurosensory retina and retinal pigment epithelium are either compromised or overwhelmed by forces attempting to detach the neurosensory retina from the retinal pigment epithelium. Forces maintaining this normal adhesion between neurosensory retina and retinal pigment epithelium include retinal pigment epithelial pump, which transfers fluid and ions between the subretinal space and the choroid, hydrostatic pressure from intraocular pressure, osmotic pressure difference between the extracellular fluid of choroid and the subretinal space, and the interphotoreceptor matrix, and interdigitation between the outer segment tips of photoreceptors and apical microvilli of RPE in the subretinal space. Types of retinal detachment include Rhegmatogenous retinal detachment, which is the most common type of retinal detachment and which we will be discussing in this session. Traction retinal detachment, which is the second most common type of retinal detachment. Combined Rhegmatogenous and traction retinal detachment, and exudative retinal detachment. And this classification is very important to remember. Rhegmatogenous retinal detachment, or RRD, occurs due to a full thickness retinal break in the neurosensory retina as seen here in this diagram, which allows fluid in the vitreous cavity to pass through this break into the subretinal space, which is a potential space between the neurosensory retina and the retinal pigment epithelium. The term rhegmatogenous originates from the word rhegma, which means break in Greek. And as we have discussed in the previous session, not all eyes with a retinal break develop a rhegmatogenous retinal detachment. The annual incidence of rhegmatogenous retinal detachment has been estimated to be between 5 and 12 per 100,000 individuals. As we have discussed in more detail in the previous session, retinal breaks can be categorized into retinal tears and retinal holes. Retinal tears include horseshoe tear or HST, as seen here in this clinical photograph, and horseshoe tear has been found to be the causative retinal break in the majority of eyes with RRDs. Operculated retinal break, as seen here in this photograph, where we find an operculum of retinal tissue hanging over the retinal break. Giant retinal tear, as seen here in this clinical photograph, and retinal dialysis, as seen here in this clinical photograph. Retinal holes include atrophic round holes, as seen here in this photograph, often within lattice degenerations, and retinal holes associated with retinoschisis, as seen here in this color photograph, and which we will discuss in more detail in a subsequent session. We had discussed about the pathogenetic sequence of the most common form of RRD, that is RRD from HST, in the previous session, and we'll go through it once more here. The initial event in the pathogenesis of RRD from HST is liquefaction of vitreous, which occurs due to fragmentation of collagen fibrils and which initially occurs in several lacunae within the vitreous cavity, which later coalesce together. Vitreous liquefaction occurs early in myopia, inherited vitreoretinopathies, ocular inflammation, and following surgery and trauma, and these are all risk factors of RRD. Following liquefaction of vitreous, posterior vitreous detachment occurs due to reduction in vitreous volume and aggregation of collagen fibrils, and following PVD, syneretic or liquefied vitreous within the vitreous cavity passes through breaks in the posterior vitreous cortex and enters the retrohyaloid space. PVD is often incomplete and progresses to completion in several stages. Following PVD, vitreoretinal traction or pull of the posterior vitreous cortex on the retina occurs at the site of vitreoretinal adhesions, causing a retinal break. Vitreoretinal adhesion is strongest at the vitreous base, as represented by the blue zones in this diagram, at whose posterior border most retinal tears are likely to occur. and ocular movements promote vitreoretinal traction because of inertia of the collapsed vitreous gel. Following the occurrence of the retinal break, there is transit of liquid vitreous from the retrohyaloid space to the subretinal space through this retinal break. Persistent vitreoretinal traction at the retinal break keeps the retinal break open and enables passage of this fluid into the subretinal space. For RRD to occur, enough fluid must enter the subretinal space to overwhelm the capacity of RPE pump to remove this fluid from the space. This subretinal fluid progresses posteriorly, thereby extending the Rhegmatogenous retinal detachment, and this is also promoted by ocular movements. Osity of eyes with macula of RRD shows loss of eyes-OS junction in the outer retina, reflecting degeneration of the photoreceptors because metabolic support to the photoreceptors is provided by the RPN choroid. Long-standing RRDs show atrophy of photoreceptors, intraretinal cystic degeneration, and signs of proliferative vitreoretinopathy, which we'll be discussing in the next session, and changes which are found after successful reattachment of detached retina include atrophy of photoreceptors, cystoid macular edema, and epiretinal membrane formation. Risk factors promoting RRD include conditions predisposing to early PVD such as high myopia, cataract surgery, posterior capsulotomy, hereditary vitreoretinopathy such as Stickler syndrome, and ocular trauma. Post-cataract surgery RRD has a higher incidence in younger patients, male sex, and with posterior capsular dehiscence during cataract surgery. Other risk factors for RRD include precursor lesions such as lattice degeneration, cystic retinal tufts, meridional folds, and degenerative retinoschisis, which we have discussed in the previous session. History of RRD in contralateral eye, family history of RRD, older age, male sex, and inflammatory entities such as Bart's planitis, acute retinal necrosis, and CMV retinitis. This is an important list. Vitreoretinal disorders typical of high myopia include myopic maculopathy such as posterior staphyloma and myopic macular degeneration, which we have discussed in an earlier session, RRD from peripheral breaks and atrophic holes, and RRD following cataract and refractive surgeries, both of which have a higher incidence in myopic eyes as compared to the general population, and three entities which are almost specific for high myopia: foveoschisis, which we'll be discussing in the session on retinoschisis, RRD from macular hole, which we'll be discussing in the session on macular hole, and RRD from paravascular microholes in the posterior pole, which are small round or oval holes along major retinal blood vessels in the posterior pole. Patients with RRDs from HSTs and GRTs present with rapid loss of vision over several days, and these patients may complain of a peripheral visual field defect in early stage when RRD extends posterior to the equator, followed by loss of central vision when RRD involves the fovea. RRDs from inferior HSTs progress relatively slowly as compared to RRDs from superior HSTs, and as compared to RRDs from HSTs and GRTs, RRDs from atrophic holes and retinal dialysis progress very slowly over several months. 50% of patients with RRD complain of flashes or increased floaters, and this may precede onset of vision loss. Flashes or increased floaters in this scenario occurs due to acute PVD, but acute PVD may occur in the absence of RRD. Flashes are more noticeable in a dark environment and floaters are more noticeable in a bright environment, but both flashes and floaters are perceived more commonly following ocular movements. On the other hand, patients with RRDs from atrophic holes and retinal dialysis do not experience flashes because these RRDs are not associated with vitreoretinal traction. On slit lamp examination, small clumps of pigmented cells, which are actually RPE cells, can be found in the anterior vitreous in 70% of patients with RRDs, as seen here in this clinical photograph, and this is called tobacco dusting appearance or Schaffer sign. Syneretic vitreous and PVD is often detectable in eyes with RRD on slit lamp examination, and intraocular pressure in an eye with RRD is usually lower than the fellow eye but may be elevated in some cases due to blockage of trabecular meshwork by dislodged photoreceptor outer segments, which is called the Schwartz-Matsuo phenomena. We must remember that Schwartz-Matsuo phenomena occurs due to blockage of trabecular meshwork by dislodged photoreceptor outer segments and not by blockage due to RPE cells. On fundus examination, the detached area of the retina appears elevated, through which choroidal and RPE details are more obscure as compared to attached areas of the retina. The detached retina in RRD typically has a convex contour and convex borders, and in a recent onset RRD, the surface of the detached retina appears corrugated as seen here in this clinical photograph and also undulates with ocular movements. These two photographs also show the typical features of RRD, convex contours and borders, and a corrugated surface. The detachment in RRD typically starts peripherally at the site of the retinal break, extends anteriorly to the ora serrata, and progresses posteriorly towards the optic nerve early in the course of the disease. These properties of RRD are in contrast to those of traction RD, which we will discuss in the next session. Traction RD has a concave contour, a smooth surface, is immobile with an extent which has no relation with either the ora serrata or the optic nerve head. With passage of time, fixed folds may appear on the surface of the detached retina due to development of proliferative vitreoretinopathy as seen here in this clinical photograph, and occurrence of such fixed folds in a detached retina almost always indicate a Rhegmatogenous origin of that detachment. Also, the detached retina has a smoother surface, appears thinner, develop macrocysts as seen here in this clinical photograph, and develop a demarcation line as seen here in this clinical photograph with passage of time. These mostly occur in slowly progressing RRD from atrophic round holes and retinal dialysis, and we must remember that demarcation line does not eliminate the risk of progression of RRD. Shifting of fluid with change in head position, which is characteristic of exudative RD, is infrequently detected in RRD. A subclinical RRD is defined as an RRD which extends more than one disc diameter from the edge of the retinal break but remains anterior to the equator and so does not demonstrate visual field defect. A retinal break as seen here in this color photograph can be identified in up to 95% of eyes with RRD, and binocular indirect ophthalmoscopy with scleral indentation or scleral depression as seen here in these two photographs enables identification of retinal breaks with a decreased chance of missing any retinal break. These two photographs show how scleral depression enables easier identification and recognition of peripheral breaks. Retinal breaks causing RRD are most commonly found in the superotemporal and supranosal quadrants, and this is very important to remember. Pseudophakic eyes with RRD may have multiple small tears in retinal periphery, and all of these retinal tears may not be identifiable during indirect ophthalmoscopy, and slowly progressive asymptomatic RRD in young low myopic eyes are usually due to atrophic round holes, often within lattice degenerations, and these atrophic holes usually are found in the temporal and inferior retina. These characteristics of RRDs in pseudophakic eyes and in young low myopic eyes are important to remember because they have implications in their management. In patients presenting with significant vitreous hemorrhage precluding complete examination, USG B scan may help to detect RRD as seen here in this ultrasonogram, as well as detect an HST. Lincoff rules help us in locating the causative or primary retinal break from the configuration of the RRD, and we'll describe these rules with the help of these diagrams which show the detached retina in blue and the attached retina in red. Rule 1 states that in a subtotal RD involving superior and inferior quadrants but with a superior wedge of attached retina, the primary break lies within 1.5 clock hours of the higher border of the detached retina in 98% of cases. Rule 2 states that in a total RRD or a superior RRD in which the detached retina crosses the 12 o'clock meridian, The primary break is near the 12 o'clock position within a triangle whose apex lies at the ora serrata at 12 o'clock and whose sides extends 1.5 clock hours on either side of 12 o'clock position at the level of the equator, with the break usually lying on the side of the lower border of the detached retina in 93% of cases. Rule 3 states that in an inferior RRD with unequal fluid levels temporally and nasally, the primary retinal break lies below the horizontal meridian and on the side of the higher border of the detached retina, and in an inferior RRD with equal fluid levels temporally and nasally, the primary retinal break lies near 6 o'clock position. Rule 4 states that in inferior bullous RRD, the primary retinal break is located above the horizontal meridian. There are additional rules which are actually variations of original Lincoff rules, and the one which is a variation of Lincoff Rule 1 states that if an RRD involves the upper and lower quadrants of the retina on the same side of the vertical meridian, the primary retinal break usually lies within 1.5 clock hours of the superior margin of the detached retina, and the rule which is a variation of Lincoff's Rule 3 states that if both inferior quadrants are detached, the primary retinal break lies either within 1.5 clock hours of the superior margin of the detached retina or along the meridian bisecting the two margins of the detached retina. We must remember that Lincoff rules do not work in eyes with posterior retinal breaks and attached vitreous, particularly in pediatric patients. Management of RRD is primarily surgical, and principles of RRD surgery is finding and closing all retinal breaks, relieving vitreoretinal traction on the break, and draining subretinal fluid so that choroid RP and retina can come close to each other for adequate chororetinal adhesion. Only in selected scenarios, conservative non-surgical management of RRD is justified, and they include asymptomatic slowly progressing RRD from atrophic round holes, asymptomatic slowly progressing RRD from retinal dialysis, and chronic RRDs in these two scenarios with demarcation line. And these patients can be followed up conservatively only if the patient is able to recognize symptoms of progression and report immediately when they occur, with or without laser delimitation of a small peripheral asymptomatic RRD in these scenarios. There are three surgical procedures available to attach a detached retina, and they are scleral buckling, pars plana vitrectomy, and pneumatic retinopexy. In this session, we'll be discussing the principles of these surgical procedures and briefly discuss their techniques, and we'll be discussing these techniques in more detail in a later session. Scleral buckling creates an indentation of the sclera from its external surface at the site of the retinal break, as seen here in this diagram. This is the scleral buckle which indents the sclera at the site of a retinal break. Scleral buckling promotes retinal reattachment by negating vitreoretinal traction on the retinal break lying over the indentation made by the scleral buckle. Buckle reduces fluid flow through the retinal break by bringing the RP choroid nearer to the retinal break, and this narrowing of the subretinal space increases fluid flow velocity within the subretinal space, which lowers the pressure within the subretinal space, thus opposing the retinal break on the RP and the choroid. So buckle achieves closure of the retinal break but does not seal the break, for which cryopexy or laser retinopexy is required. This clinical photograph shows the ophthalmoscopic view of a retina, the peripheral portion of which has been indented by a scleral buckle. Scleral buckling is preferred in eyes where vitreous is still attached to the detached retina, and these include young myopic phakic eyes with RRD from atrophic round holes and RRDs from retinal dialysis. Vitrectomy is not indicated in these scenarios because of potential difficulty of removing vitreous attached to the detached retina. The landmark SPR study showed that in comparison to vitrectomy, scleral buckling resulted in significantly better visual acuity in phakic eyes, and as we shall see, the same study showed that in comparison to scleral buckling, vitrectomy has a higher anatomical success, that is retinal reattachment rate, in pseudophakic eyes. For a limited retinal detachment with a single break, either a radial element called a sponge as seen here in this photograph, or a small circumferential segmental buccal called a tire, whose required length is obtained from the commercially available tire, is used to indent the region of the break. And many surgeons prefer to add an encircling band along with the circumferential segmental buccal because these have been shown to prolong the duration of buccal-induced indentation of the sclera, but usage of these encircling bands have been associated with higher incidence of motility disturbance, refractive shift and buccal erosion. This photograph shows a radial sponge, this photograph shows a tire with an encircling band, and this photograph shows a tire with an encircling band whose ends are secured with a sleeve. This whitefield fundus photograph shows indentation by a tire in this portion of the peripheral fundus, with indentation by the associated encircling band in the remaining portion of the fundus. And this photograph shows indentation by a tire with an encircling band being augmented by a radial sponge. Briefly, the steps of scleral buckling are local anesthesia, conjunctival peritomy, hooking and securing of the rectus muscles, identifying all retinal breaks and creating chororetinal adhesion around them as seen here in these two photographs, with this showing the early appearance and this showing the later appearance of the same freeze with cryo, positioning of buccal and placement of buccal sutures, drainage of subretinal fluid through a sclerotomy as seen here in this photograph, securing the buccal with the pre-placed buccal sutures, rechecking the position of the explant with respect to the breaks, intraocular air injection if subretinal fluid drainage resulted in hypotony, followed by conjunctival closure. Pars plana vitrectomy or PPV allows relieving vitreoretinal traction, draining subretinal fluid internally, and laser photocoagulation around retinal breaks. PPV can be employed in almost all cases of RRD, but as we have discussed, should be avoided in situations where vitreous is still attached to the detached retina, as in young myopic eyes with RRD from atrophic holes and eyes with RRD from retinal dialysis. PPV for RRD is preferred in pseudophakic eyes, which usually have small and multiple anterior retinal breaks which are liable to go undetected during preoperative examination along with PVD. And as we have already mentioned, the SPR study found that PPV resulted in a higher anatomical success rate, that is retinal reattachment rate, in pseudophakic and aphakic eyes as compared to scleral buckling, though visual acuity difference was non-significant. PPV is also preferred for RRD with posterior breaks which cannot be adequately supported with scleral buckle, and for RRD eyes with thin sclera in which scleral buckling is difficult. Other RRD situations in which PPV is preferred include giant retinal tears, bullous RRD, retinal breaks in multiple quadrants, prolonged macular detachment, RD from macular hole, older patients with PVD and pseudophakia, ocular hypotony, and proliferative vitreoretinopathy. We will be discussing about PVR in the next session and about macular hole in a subsequent session. For PPV, local anesthesia is preferred if possible, as patient can be positioned immediately after surgery following local anesthesia. Initially, complete vitrectomy is done with removal of all vitreous traction, following which a heavy liquid can be injected into the vitreous cavity to settle the posterior retina, move the subretinal fluid anteriorly and out through the retinal break into the vitreous cavity, and facilitate vitreous base dissection. PFCL is indicated for eyes with bullous RRD with all the breaks anterior to the equator. Then the fluid or PFCL in the vitreous cavity is removed and replaced with air, followed by internal drainage of the subretinal fluid through the retinal break, and after the retina is reattached, laser photocoagulation is applied around all retinal breaks, which can be done under air or through the PFCL bubble. Then an intraocular tamponade is administered to support reattachment of the retina for a period of time after surgery, and this can be done either with non-expansile gas air mixture or with silicone oil. If pure gas is injected inside the eye, it will absorb nitrogen and oxygen from intraocular fluid and expand in volume, dramatically increasing the intraocular pressure post-operatively. But prior to injection, If this gas is diluted with air to these respective maximum concentrations, it will no longer expand after injection inside the eye, and thus post-operative rise in IOP is prevented. Such non-expansile gaseous mixtures is preferred in uncomplicated RRD, and silicone oil is considered in eyes with multiple inferior breaks, proliferative vitreoretinopathy, and in only seeing eyes. Along with PPV, many surgeons prefer to put a supplementary scleral buckle or band to support the vitreous base, as complete vitreous base removal is not possible, but the Viper study found that there was no additional benefit of an encircling band in primary reattachment rate in primary pseudophakic RRDs undergoing PPV. Following surgery, patient is instructed to assume a face-down position as early as possible to promote early attachment of the macula. In contrast to scleral buckling, PPV provides better view of retinal periphery and allows identification of all retinal breaks, allows more complete drainage of the subretinal fluid, has a reduced risk of intraocular bleeding, eliminates the risk of retinal incarceration during external drainage of subretinal fluid during buckling, is less likely to cause a refractive change, allows combined cataract surgery along with PPV, but has a higher risk of cataract, typically nuclear cataract progression and proliferative vitreoretinopathy. Pneumatic retinopexy or PR is a much less invasive surgical procedure which consists of intravitreal injection of pure gas along with transconjunctival cryopexy or laser photocoagulation, followed by a period of appropriate post-operative head positioning, but only in selected cases. Buoyancy of the gas bubble exerts upward pressure on the detached retina, and surface tension of the gas bubble closes the retinal break without allowing the gas bubble to enter the subretinal space through the retinal break. In PR, pure gas is injected, which expands for the initial few days by drawing nitrogen and oxygen from intraocular fluid, and then the bubble gradually decreases in size over the next several weeks. But unlike scleral buckling or PPV, PR does not neutralize or relieve existing vitreous traction. Either 0.5 ml of SF6 or sulfur hexafluoride is injected, which doubles in size in the next 36 hours and then persists for 12 days on average, or 0.3 ml of C3F8 or perfluoropropane is injected, which quadruples in size in the next 3 days and then persists for 38 days on average. Case selection for PR is extremely important, and contraindications or relative contraindications to PR include detached inferior retinal breaks between 4 o'clock and 8 o'clock positions, detached retinal breaks extending for more than 1 to 2 clock hours, proliferative vitreoretinopathy, inability of the patient to maintain required post-operative head position, uncontrolled glaucoma, pseudophakia or aphakia, and cloudy media. PR can be done in one sitting or staged at 2 sittings. In one sitting PR, initially cryopexy is done followed by gas injection, and in 2 sitting PR, the gas is injected in the first sitting followed by laser photocoagulation 2 to 3 days later. Steps of PR include topical or peribulbar anesthesia, transconjunctival cryopexy in one sitting PR as shown here in this clinical photograph, paracentesis to reduce intraocular pressure, intravitreal gas injection through pars plana, checking intraocular pressure and perfusion of central retinal artery following intravitreal gas injection, and repeating paracentesis if required, which is very important. Instructing the patient to maintain the appropriate head position as early as possible following surgery, and laser photocoagulation after 2 to 3 days following retinal reattachment in 2 sitting PR. In selected cases, compared to scleral buckling and PPV, PR has comparable anatomic success rate, often with better visual outcome, lower morbidity, less cost, and lower incidence of complications such as cataracts. PR is also a viable treatment option when following scleral buckling surgery. The retinal break remains elevated away from the buccal instead of being settled over the buccal. It is said that after any type of RRD and its management, 40% of patients do not achieve reading ability, 10% to 40% need more than one surgical procedure, and 5 to 10% have permanent anatomical and visual failure. The anatomical success rate or retinal reattachment rate of primary scleral buckling and primary vitrectomy for RRD are equally high. A Cochrane review in 2019 comparing scleral buckling with pars plana vitrectomy for primary RRD with breaks up to 2 clock hours in extent in phakic, aphakic or pseudophakic eyes found little or no difference with regard to anatomic success or visual gain. In this study, PPV was associated with a lower rate of redetachment, a higher rate of progression of cataract, and a higher incidence of iatrogenic breaks. On the other hand, scleral buckling in this study was associated with a higher incidence of choroidal detachment, but most agree that PPV with or without buckling is superior to scleral buckling alone in pseudophakic RRD. In properly selected cases and with adequate adherence to post-operative regimen by the patient, pneumatic retinopexy also has a high success rate. Recurrent retinal detachment can occur in 10 to 20% of eyes following primary surgery, and cystoid macular edema occurs in 5 to 10% of eyes following surgery for RRD. Epiretinal membrane formation following vitrectomy is higher than that following scleral buckling, and this has been linked to the drainage retinotomy made during vitrectomy. Visual recovery following surgery for RRD depends on presence of detachment of macula prior to surgery and duration of macular detachment prior to surgery, and this is very important to remember. It has been found that 73% of eyes with macula on or macula attached RRD regain 20/40 or better vision, while only 14% of eyes with macular detachment for more than 6 weeks prior to surgery regain 20/40 or better vision. The most common reasons for redetachment are failure to identify and treat all retinal breaks, proliferative vitretinopathy, which we'll be discussing in the next session, and occurrence of new retinal breaks. The risk factors for poor outcome following surgery for RRD include duration and extent of RRD, macular detachment, inferior retinal breaks and or inferior RRDs, absence of detectable retinal breaks, high myopia, hypotony, proliferative vitretinopathy and its risk factors, and older age. To recap the salient points, retinal detachment is a separation of the neurosensate retina from the retinal pigment epithelium. RD can be classified into Rhegmatogenous RD, traction RD, combined traction Rhegmatogenous RD, and exudative RD. RRD occurs from a full thickness break of the neurosensate retina, which allows liquefied vitreous to pass into the subretinal space between and separating the neurosensate retina and the retinal pigment epithelium. Most RRDs occur from a horseshoe tear, which usually occurs at the posterior edge of the vitreous base due to vitreous traction following vitreous liquefaction and posterior vitreous detachment. Other forms of full thickness retinal breaks due to vitreous traction which can lead to RRD include giant retinal tear and operculated retinal hole. RRD can also occur from full thickness retinal breaks which occurred in the absence of PVD and vitreous traction, such as atrophic round holes which typically occur in young myopes, and retinal dialysis which typically occurs following trauma. Risk factors for retinal breaks and RRD include myopia, pseudophakia and aphakia, family history of RRD, history of RRD in fellow eye, certain peripheral retinal degenerations, ocular trauma, older age, male sex, ocular inflammations, and hereditary vitretinopathies. Patients with RRD from HST and GRT have rapid progression of symptoms from a peripheral visual field defect to loss of central vision, along with complaints of flashes and increased floaters. RRDs from atrophic holes and dialysis are slowly progressing, and these patients do not complain of flashes. On examination, eyes with RRD may have pigment clumps in anterior vitreous with a low intraocular pressure. Some eyes with RRD have raised intraocular pressure due to blockage of trabecular meshwork by outer segments of photoreceptors. The detached retina appears corrugated, undulates with ocular movements, and has a convex contour and convex borders. The detachment typically progresses from the retinal break to the ora serrata and from the retinal break posteriorly up to the optic disc margin. Old RRDs show signs of proliferative vitreoretinopathy such as fixed folds and funnel configuration of the retina and demarcation line surrounding the detached retina. Indirect ophthalmoscopy with scleral depression is essential to identify all retinal breaks. Causative or primary retinal breaks in eyes with RRD are most commonly found in the superotemporal and superonasal quadrants. Lincoff's rules help us to locate the primary retinal break from the configuration of the detached area of the retina. Management of RRD is primarily surgical. Principles of surgery are to find and close all retinal breaks, relieve vitreous traction, and drain subretinal fluid. Techniques include scleral buckling, pars plana vitrectomy, and pneumatic retinopexy. In scleral buckling, a scleral explant is sutured to the sclera to indent the sclera at the site of the retinal break. Prior to that, cryotherapy is applied to the retina surrounding the breaks to close the breaks. External drainage of subretinal fluid can be done with a sclerotomy. Scleral buckling is preferred in phakic Rhegmatogenous retinal detachment, where it results in better visual outcomes as compared to PPV, and in RRDs from atrophic holes and retinal dialysis, because in these scenarios the vitreous is adherent to the detached retina and is difficult to remove by pars plana vitrectomy. In pars plana vitrectomy, near complete removal of vitreous is possible, along with internal drainage of subretinal fluid, closure of the retinal breaks with laser photocoagulation, and administration of an internal tamponade. PPV is preferred in pseudophakic eyes, where it gives better anatomical outcomes as compared to scleral buckling. PPV is also preferred in eyes with giant retinal tears, bullous RRD, eyes with retinal breaks in multiple quadrants, posterior retinal breaks, thin sclera, and proliferative vitreoretinopathy. PPV is not the primary surgical option in RRD from atrophic holes and retinal dialysis, where vitreous remains adherent to the detached retina. In pneumatic retinopexy, after cryotherapy to close the retinal break, a gas is injected in the eye, followed by head positioning by the patient. PRD is considered only in selected cases of RRD, such as a localized superior RRD with a single or few breaks clustered in a region less than 2 clock hours in extent. PRD is contraindicated in proliferative vitreoretinopathy, inferior breaks, breaks in multiple quadrants or extending for more than 2 clock hours, inability of patient to maintain required position post-operatively, aphakia or pseudophakia, and uncontrolled glaucoma. Poor prognostic factors for anatomic and functional success of surgery for RRD include duration of macular detachment prior to surgical reattachment, inferior breaks, absence of detectable retinal breaks, high myopia, hypotony, and proliferative vitreoretinopathy and its risk factors. Thank you for listening.